Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 335 of our Pharmacotherapy MCQ series, which majors in medication therapy management and assessment of therapy.
The first question reads, PJJ, a 45-year-old woman of normal height and weight, states that she has diabetes mellitus. What questions might the practitioner ask PJJ to determine whether type 1 or type 2 diabetes mellitus should be documented in her medical history? Patients usually can enumerate their medical problems in a general way, but the practitioner often will have to probe more specifically to refine the diagnosis and assess the severity of the condition. Diabetes mellitus is used to illustrate the types of questions that can be used to gather important health information and assess drug therapy. The following questions should generate information that will help to determine whether PJJ has type 1 or type 2 diabetes. How old were you when you were told you had diabetes? Do any of your relatives have diabetes? What do you know of the diabetes? Do you remember your symptoms? Please describe them to me. What medications have you used to treat your diabetes? When questions such as these are combined with knowledge of the pathophysiology of diabetes, appreciation of the typical presenting signs and symptoms of the disease, and understanding of the drugs generally used to treat both forms of diabetes, meaningful MTM can be provided. Let's first discuss medication history. In the community pharmacy setting, patients generally present themselves in one of four ways. A. With a self-diagnosed condition for which non-prescription drug therapy is sought. B. With a newly diagnosed condition for which a drug has been prescribed. C. With a chronic condition that requires a refill of a previously prescribed drug or the initiation of a new drug, or D. Upon referral from their health plan or provider, or self-referral for focused medication therapy review, abbreviated as MTR. In the first and second situations, the practitioner must confirm the diagnosis by using disease-specific questions as illustrated in question 1. In the third situation, the practitioner uses the same type of questioning as in the first two situations. However, this time the practitioner needs to evaluate whether the desired therapeutic outcomes have been achieved. The practitioner must evaluate the information gleaned during follow-up visits in the context of the history and incorporate it into his or her assessment and medication action plan, abbreviated as MAP. In the fourth situation, in which patients require a focused medication therapy review, the medication and medical history information are equally important. Without the medical history, it is not possible to evaluate whether the drug therapy is appropriate, and without an accurate medication history, it is not possible to determine whether the patient has reached the desired goals of therapy for her condition. The goal of the medication history is to obtain and assess the following information. The specific prescription and non-prescription drugs that the patient is taking, such as over-the-counter medications, botanicals, dietary supplements, recreational drugs, alcohol, tobacco, and home remedies. The intended purpose or indications for each of these medications. How it is taken, e.g., route, ingestion in relation to meals, how much, and how often these medications are used. How long these agents have been taken or used, start and stop dates. Whether the patient believes that any of these agents are providing therapeutic benefit. Whether the patient is experiencing or has experienced any adverse effects that could be caused by each of these agents, idiosyncratic reactions, toxic effects, or adverse effects. Whether the patient has stopped taking any of the medications for any reason. And allergic reactions or history of hypersensitivity or other severe reactions to drugs. This information should be as specific as possible, including a description of the reaction, the treatment, and the date of its occurrence. A successful medication reconciliation process consists of a standardized systematic approach, with the initial step in this process involving the collection of the best medication history possible from every patient that enters any point in the healthcare system. Although pharmacists are uniquely qualified and have demonstrated increased accuracy in acquiring the medication history, medication reconciliation requires a multidisciplinary effort in which all available resources are integrated into each step of the process when appropriate. Shared accountability by using key members of the health care team such as nurses, pharmacy technicians, pharmacists, and prescribers is essential in this process. Once an accurate medication history is obtained, this information is used to ensure that as the patient moves through the healthcare system, any deviation from prescribed regimen is deliberate and based on acute changes in the patient's condition. If an observed discrepancy is the result of an intended therapeutic decision by the prescribing clinician, appropriate documentation with either the reason for or intention to change, hold, or discontinue the medication should be completed in a manner that is clear to all members of the healthcare team. Unintentional variances in the medication lists should be considered as potential medication errors pending clarification from the prescribing clinician. Medication errors most commonly occur during transitions of care. It is essential to conduct medication reconciliation when a patient is admitted to or discharged from a healthcare facility. A crucial final step in the reconciliation process, and a vital piece of MT-MUS, occurs at discharge to avoid therapeutic duplication, drug interactions, and omissions of medications that may have been discontinued or placed on hold during hospitalization. On departure from a healthcare facility, a complete list of the patient's medications must be communicated to the patient and the next provider of service regardless of the setting. This process allows for informed prescribing decisions and creates a safer environment for patients by improving the accuracy of medication administration throughout the continuum of care. Perhaps the most important aspect of the medication history is to ensure that no assumptions related to medication use go unverified with the patient. The provider should ask questions related to how the current medication therapy is actually taken by the patient. The interviewer should then compare the use of medications as defined by the patient to the prescription information on the prescription bottle or in the PIS or EHR. This information may identify discrepancies or misunderstandings between the prescriber and the patient. The patient may not have adequate health literacy, and the interpretation of the medication instructions printed on the bottle or described by a health professional may not be understandable to a patient. The review of the medication history is an ideal time to identify and clarify such misunderstandings. The next question reads, PJJ has indicated that she is injecting insulin to treat her diabetes mellitus. What questions might be asked to evaluate PJJ's use of and response to insulin? The following types of questions, when asked of PJJ, should provide the practitioner with information on PJJ's understanding about the use of and response to insulin. Regarding drug identification and use, we can ask the following questions. What type of insulin do you use? How many units of insulin do you use? When do you inject your insulin? Where do you inject your insulin? Please show me how you usually prepare your insulin for injection. This allows the patient to demonstrate a skill. What, if anything, keeps you from taking your insulin as prescribed? Regarding assessment of therapeutic response, we can ask the following questions. How do you know your insulin is working? What blood glucose levels are you aiming for? What foods or meals do you find affect your blood sugar most? How often and when do you test your blood glucose level? Do you have any blood glucose readings that you could share with me? Please show me how you test your blood glucose. What is your understanding of the hemoglobin A1C blood test? When was the last time you had this test done? What were the results of the last hemoglobin A1C test? Regarding the assessment of adverse effects, we can ask the following questions. Do you ever experience reactions from low blood glucose? What symptoms warn you of such a reaction? When do these typically occur during the day? How often do they occur? What circumstances seem to make them occur more frequently? What do you do when you have low blood glucose? The patient's responses to these questions on drug use, therapeutic response, and adverse effects will allow a quick assessment of the patient's knowledge of insulin and whether she is using it in a way that is likely to result in blood glucose concentrations that are neither too high nor too low. The responses to these questions should also provide the practitioner with insight about the extent to which the patient has been involved in establishing and monitoring therapeutic outcomes. Based on this information, the practitioner can begin to formulate the patient's therapeutic plan. Regarding social history, the social history is used to determine the patient's occupation and lifestyle, important family relationships or other support systems, any particular circumstances, e.g., a disability, or stresses in her life that could influence the medication action plan, and attitudes, values, and feelings about health, illness, and treatments. The next question reads, a patient's occupation, lifestyle, insurance status, ability to pay, and attitudes often can determine the success or failure of drug therapy. Therefore, PJJ's prescription drug coverage, nutritional history, her level of activity or exercise in a typical day or week, the family dynamics, and any particular stresses that may affect glucose control need to be documented and assessed. What questions might be asked of PJJ to gain this information? With regard to work, we can ask a question such as, please describe your typical workday and a typical weekend day. With regard to insurance or cost, we can ask a question such as, what type of prescription drug coverage do you have? How much do you pay for your insulin and diabetic supplies? How often do you go without your insulin or supplies because of cost? With regard to exercise, we can ask questions such as, describe your exercise habits. How often, how long, and when during the day do you exercise? Describe how you change your meals or insulin when you exercise. With regard to diet, we can ask questions such as, how many times per day do you usually eat? Describe your usual meal times. What do you usually eat for each of your main meals and snacks? Are you able to eat at the same time each day? What do you do if a meal is delayed or missed? Who cooks the meals at home? Does this person understand foods to prepare for someone with diabetes? How often do you eat meals in a restaurant? How do you order meals in a restaurant to maintain a proper diet for your diabetes? Note, this is asked to patients who frequently dine in restaurants. With regard to support systems, we can ask questions such as, who else lives with you? What do they know about diabetes? How do they respond to the fact that you have diabetes? How do they help you with your diabetes management? Does it ever strain your relationship? What are the issues that seem to be most troublesome? Note, these questions apply equally to the workplace or school setting. Often, the biggest barrier to multiple daily injections is refusal of the patient to inject insulin while at work or school. With regard to attitude, we can ask questions such as, how do you feel about having diabetes? What worries or bothers you most about having diabetes? Note, participate in the patient's care. This approach is likely to enhance the patient-provider relationship, which should translate into improved care.
So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 336.